So we're going to talk about the potentially malignant disorders. Now, I don't have time in this hour to talk about all of these things. We're going to hit leukoplakia the hardest, simply because it is the most common way in which these potentially malignant disorders present. The first thing I want to say about leukoplakia is when I say leukoplakia, I mean something very specific. So leukoplakia is defined by the WHO as a white plaque of questionable risk, having excluded other known diseases or disorders that carry no risk. And that's a long way of saying it's a white plaque. We don't know why it's there. So other things can present as white plaques, like tobacco pouch keratosis. That presents as a white patch, but we know why it's there. This I would also sign as hyperkeratosis, because that's what it is, but this lesion is not meant to be watched. So I just wanted to sort of point out the difference in what I mean when I say leukoplakia, because it relates to the treatment plan. So about 85% of potentially malignant disorders present as leukoplakia. Not all of these go on to cancer, and we don't know which ones will. And in fact, most of the time when you are doing a biopsy on true leukoplakia, you're just going to get hyperkeratosis, benign hyperkeratosis, 80% of the time. But like I said, if it's an area of true leukoplakia, we still have to watch these. You will typically see the leukoplakias on the lip vermilion, the buccal mucosa, and the gingiva. However, the ones with dysplasia and carcinoma are found in those high-risk areas: lip vermilion, lateral ventral tongue, and floor of mouth. This is a sharply defined lesion. It's on the lateral border of the tongue. We don't know why it's there. The fact that it's sharply defined, it means that there's one cell sort of crawling around the edge of it, and it's not a chewing thing. You can see it's slightly fissured. This was biopsied, and it was just hyperkeratosis. This was mild dysplasia. This was hyperkeratosis, but it's good they took two different pieces, because now we need to treat the whole lesion like it's mildly dysplastic, meaning this white has to be destroyed. Whereas if it was just hyperkeratosis, we could afford to watch it. This is a thick leukoplakia that's starting to get surface irregularities. You can appreciate here it's thinned out a little bit. This was severely dysplastic. Probably this area specifically was severely dysplastic. We've got thin leukoplakia, progresses to thick, progresses to nodular, granular, verruciform, whatever term you like. Now, if that progresses, then the lesion starts to get red patches. That's called erythroplakia. So the erythroplakia, what it means is the cells are turning over so rapidly. They are so immature because they keep turning over so quickly that they don't have time to do what they're supposed to do. And what their epithelial cells are supposed to do is produce keratin. So because they're not producing the keratin, the lesion is not white. It's red. Here is a very thin, very faint leukoplakia, but there's erythroplakia around it. This was severe dysplasia. The old thought is, let's wait a couple weeks to see if things clear up. But the new thought, and now the evidence-based clinical practice guidelines I was telling you about earlier, says if you think something is a potentially malignant disorder like those we've been talking about tonight, you either biopsy it yourself, that appointment, or you refer for biopsy immediately if you don't do your own biopsies. So after the biopsy report comes back, what do you do with your diagnosis? Well, number one, if it's true leukoplakia, you must follow up every 6 months. The literature says for 20 years. And if the lesion changes in any way, it requires rebiopsy. Mild dysplasia, take it out. You can laser it. That's probably fine with mild dysplasia, but I recommend to destroy the tissue. If it's moderate dysplasia or worse, the standard of care is to destroy the tissue. If it's moderate dysplasia or worse, I recommend taking a scalpel, doing a conservative surgical excision, putting a suture in it to orient it, and then sending it to me, and I'll look at your margins. Or your favorite oral pathologist. So long-term follow-up every 6 months, because you get frequent recurrences and additional lesions.